Good afternoon and welcome to Sam Houston State University's first fall CME offering. Our presenter today is Dr. Stephen McKernan, Associate Dean for Clinical Affairs here at SHSU's College of Osteopathic Medicine. Dr. McKernan has been trained as a pharmacist, an ND, and osteopathic physician, and is board certified by the American Board of Family Medicine and the American Osteopathic Board of Family Physicians. Prior to joining Sam Houston State University, Dr. McKernan practiced in a rural community in Central California, was a member of the faculty at Kirksville College of Osteopathic Medicine, and was CEO and Family Medicine Residency Program Director of Lone Star Family Medicine Residency Health Center, an FQHC-based teaching health center in Conroe, Texas. Today, we will be covering teaching medical students in a clinical setting. But before we start, a couple of housekeeping items. First, we invite you to ask questions through the Q&A button located in your Zoom toolbar. So please feel free to use that function during the presentation, or you're welcome to wait until the end. A quick FYI that the survey provided at the end will direct you to claim your credit. However, I will also provide all of this information in a follow-up email. And with that, Dr. McKernan, I hand the floor over to you.
So what we're going to talk about today is teaching medical students. And this is important because I know that many of you have not done this in a long time. Some of you had, but we're hoping that this talk can actually make you more confident when our students arrive in August of 2022. All right, so based on this presentation, we really want you to meet these objectives of understanding the role of a teaching physician in the clinical setting and utilize techniques to save time while while providing education to students. We really want this to be a positive experience for both the attending physician as well as students, to become aware of patient responses to medical students in the clinical environment, to appreciate the medical student documentation and its role in patient care, and to create positive learning environments for students while meeting patient needs and patient satisfaction. And we want you to realize the benefits of being a teaching physician and participating in education of future physicians. This is something that I have done my entire career, both when I was in my own practice and as an academic in academic world. And so it's something that I always enjoyed and went to it with that in mind. Not working. I better change the slide for me. All right, so first thing about being attending physician, and the most concern that many people have is that they think that's going to decrease their productivity. And really, clinical teaching should not decrease your productivity. In fact, it could have a positive effect on your practice. The presence of medical students in a practice is also a concern that people say, well, I'm in a private practice. My patients wouldn't like having a medical student. Well, the patients actually like that. It improves patient satisfaction in a couple of ways. They view their doctor as a teacher, which they like, but they also look at it as two sets of eyes. Remember, medical student has training and patients realize that, so that they view a medical student working with the doctor as something that is a positive for the most part. The other thing is many physicians actually enjoy the teaching. I always did. Teaching students reminds us of why we wanted to do this, and it brings us back to those people who did it for us. In my career, I've taught students, but in my medical school and residency career, I had people who taught me and enjoyed teaching me. So it does bring back some of the joy of being a physician and being in medicine. And then teaching medical students is also giving back, a way we have all had mentors in the past who encouraged us and really molded us. Physicians can have that role and really make a positive experience for medical school for students. And then being involved in medical education can remind us of why we became physicians. Students come in enthusiastic, they come in as open books. And having that in the office actually can lift an office in a way. Having it in the hospital makes a hospital seem like a more academic place, which is also a, lifts the spirits of a lot of people. So the main concern about productivity is really not founded. High productivity does not preclude quality teaching. Often clinical faculty feel that the need for productivity is a limiting factor in their ability to teach medical students. What I hear often is that, oh, I'm too busy to have a medical student. And the reality is that a medical student can help that busyness. A study in Academic Emergency Medicine journal showed that there was no statistically significant difference, significant relationship between the clinical productivity and the teaching environment. And in fact, the more productive the attending physician was, the more highly rated their teaching was, because those physicians found ways to take the students and give them things to do that were important to help them get through their day. And so students like that. They like to do things that actually make a difference in a patient's life. So teaching should not require reduction in patient encounters. And actually, you can sometimes fit extra patients in and see patients quicker when a student is with you. And I will go over how that is done in some examples. The other thing is, went too fast. She went too fast. The other thing is, learners do not decrease productivity in other professions, in nursing or pharmacy. So in medicine, it should be the same. So what can students do? Well, they can research difficult or interesting cases. So when someone comes in and the physician is unfamiliar with something, a student can actually look that up and review it. The current technology allows them to do that in a very rapid way so that it can be done while the patient is still with the physician. It's also a good learning opportunity for the students to learn how to use those point of care tools. It helps them understand evidence-based practice and that you can always do that. The other thing is that they've been given assignments and time to do them based on what they see during the patient care day. So whether in the hospital, they're in the office, wherever they are, there's better learning when they attach some medical concept to actually a patient they've seen. It results in more long-term memory. And students can review diagnostic texts, report on abnormal findings, and bring that to the attending physician. And this can be done best with the patient they have seen, but also can be sometimes as an effort to do things that maybe they haven't seen. It can also be for things that they will see, or maybe some interesting cases. And we all have those that we see, and sometimes the student isn't there for the case, but having them review that case, even if they don't see the patient, is valuable, especially if the physician is enthusiastic about it. So medical students also do not need constant attention. These are adult learners. So medical students should be encouraged to employ self and peer-to-peer learning. There'll be other medical students around them, and they should use those other medical students to discuss. That's how we're teaching in the medical school. The lecture idea to learn is no longer the most common method. We usually use students teaching each other and help them with that teaching. So really don't feel that students have to be with you all the time and have to be taught all the time. We really would like to have 2 students on each rotation. We haven't accomplished that yet because of our small class and some concerns from some of our affiliates and physicians, but having 2 on a rotation actually allows them to teach each other in a more simple way. And then medical students can see patients that take up time that the attending could use that time to see other patients. And the example of patients of long histories can be seen by students with the patient's permission, and they can abbreviate the story for the attending. The other thing is patients like that the student can listen to them for a long time and give them more time than an attending. And so you can use that to your benefit. And this is also a good teaching opportunity for students to learn to listen and form a comprehensive report, which they'll have to do for themselves, but initially they can do for their attending physician. So students can see patients and do your documentation. You should realize that in 2018, they changed the rules and Medicare will accept student documentation as long as the attending attests to it. And we'll go into more detail on that. But it allows you to work faster through your day. Look at it as if you had a scribe who you don't have to be in the room with. It's a very positive experience to have the student do this for you because they can go in and see the patient and they can actually document most of the chart, and then the attending can go in and make some of the therapeutic decisions. Certainly when a student does documentation, the attending should change anything they disagree with. And we've all been in the situation where someone goes in and sees a patient. Often they've been seen in the emergency room and then in a hospital bed, and the attending goes in and there's a change in the story because the patient has thought about some of the things that they were asked and have a different answer. And so students can see patients in advance of the attending's physician's presence in that room. And that helps the attending get through their day. So if the student is doing a lot of the documentation in the electronic record, it frees up the attending. So that revised decision by CMS was in 2018 in the claims processing manual that allowed attendings to verify rather than redocument student entries into the medical record. And that's all areas of the medical record. Prior to that, you could accept very little of what a medical student could do, but CMS finally realized that medical students have training and that physicians should be able to accept their documentation. That documentation is available from CMS to show you that you can bill for these services at the same E&M level with student documentation as you would if you documented, although the student documentation has to be verified. So what about patient satisfaction? That's another issue that comes up quite frequently. I never had patients complain about having a student in the office. Certainly a patient has the right to say, no, I don't want a student in the office, just like sometimes they come in and they don't want to tell a medical assistant or a nurse what they're in for. So there is that opportunity for them to request privacy. But it all depends on what the attending approaches it with. So the study in HMO in Massachusetts in 2000 showed that 93% satisfaction with or without student participation. The student participation did not affect the patient's satisfaction with their facility or their visit. And medical student participation does not impact any Press-Ganey scores for quality in an emergency department, where it's very high risk. So patients are okay with having students. And so patient acceptance of medical student participation in their care is largely the desire to contribute to the education of others. They view that as a compliment that they're asked to do that. So providing the patient gives consent, and that consent should be done before the student is in the room, they really have a positive view of having students work with their physician. So the attending role in the patient participation and their perception of what's going on really is based on how the attending physician approaches it. And so it's important to define the role of students in your practice, and that can be done by the physician, it can be done by a front office person, it can be done by nursing. But really having a positive view of it gives the patient a positive view of it. Again, you obtain consent of the patient. That can be done by the physician or the staff. And to describe the level of oversight the attending will have with students. Then we want the patients to know that the student isn't making independent decisions. The student is there to help the physician, to learn from the physician, but the physician is making the final decisions. And then to provide a positive view of the medical student participation in the patient's care. And so a physician who says in a positive way that I'm now taking students and they're helping with the care of patients in a positive way will actually be a better way to approach students in the practice. Identified advantage of medical student participation are a few. Patients typically get more time with the students than with their attending physicians. And that's just because that's what medical students do. And although for us, it seems like it takes too long, for patients, they feel like they're getting a lot of attention. Patients get two sets of eyes reviewing their case. They view it that way. They say, well, now I have this student who's talking to a doctor, they're both educated, and they think they're getting better care. Students often perform a more thorough physical exam, as you know. They usually do nearly completed physical exam. And so that is a positive thing that patients recognize also. And that's not that we should always do that, but patients actually like it. And then academic activity, whether it be in an office or a hospital or other settings, actually can raise the level of care and keep practices current. Students can bring things to the practice by doing research for the physicians with current guidelines and other things that help raise the level of care that the practice can provide without the attending physician having to do all the research for it. So what are the perks overall for teaching medical students? Well, it helps practicing clinicians keep abreast of new techniques in medical education. And medical education has changed a lot since I started. We have a whole simulation lab on the second floor of this building, which students use mannequins and all other things to get ready for actually seeing patients. And that is viewed as a safety effort. And I don't know if you're aware, but the first company to produce those mannequins was a company from Canada that did flight simulation equipment. And so flight simulation was done for safety, and it was felt that using mannequins for students in medicine and nursing could actually increase safety. It also provides a connection to an academic institution. So when attending physicians have a need for some academic activity, whether it be library access or research or anything, we're here to help for that. It contributes to the community and the medical profession. So as you probably realize, we have come mainly to places that have difficulty finding physicians in the area. And so bringing this in actually is a contributor to that, because a lot of new graduates of residency programs going out into practice like the idea that the place they're going has medical students. It brings a sense of enjoyment to practice, like I said earlier, because it reminds us of why we did this, and it brings a fresh view of medicine at a time when we're all really tired of some of the things that we have to do. It provides an opportunity to share knowledge that cannot be gained in any didactic session. So your experience, your knowledge, your ability to tell stories about patients is actually something that helps students remember why they went into medicine, even though they're going through a difficult time in learning, but also brings back the altruism that they went to medical school for. It also elevates a patient's image of the physician as a faculty member. We're no smarter the day we take a student than we were the day before. But for some reason, patients think that once you become a faculty member, you're smarter. And we'll accept that, right? So I'm going to give you some examples of productivity. Let's say Mrs. Smith, who's 85, comes in with complaints of leg pain and stiffness. Mrs. Smith lives alone, and she has one daughter. Her daughter comes and visits her, but she lives in another town and works, so she sees her on occasion. So quite frankly, Mrs. Smith needs someone to talk to. And she always gives a very detailed history of every complaint she has. So you send a medical student in, the medical student spends a lot of time with her, and the medical student listens to all of her complaints and gets a synopsis of them. And then she's happy to have that, because now somebody's listening to her. Somebody can talk to her for a longer time than an attending physician can. So Mrs. Smith is happy. So the student spends 25 minutes with Mrs. Smith. He gets a big, long history. And then he comes out to you, and in less than 5 minutes, he can relate Mrs. Smith's 25-minute story to you as the attending physician. So when you, Dr. Jones, you enter the room, you can acknowledge that Mrs. Smith allowed the student doctor to see her, and there's a typo there, quickly reviews what they discussed. So Mrs. Smith knows that you and the student had a discussion. She doesn't realize it's not 25 minutes. And then she agrees with your synopsis. And then instead of a 30-minute visit with Mrs. Jones as the attending physician, you end up with a 15-minute visit, and everyone is pleased with the encounter. You have a happy medical student, happy attending, and a happy Mrs. Smith. That's kind of the way you use the student to get them experience, as well as to get you some productivity improvement. So the next case is Mr. Jones, not related to Dr. Jones. He comes in with a complaint of sudden fatigue, periods of confusion, and near stupor witnessed by family members and coworkers, and a recent weight gain. He has a family member who has diabetes, and his blood sugar was checked during one of his episodes and was found to be only 24. He has begun eating dried fruit through the day to keep his blood sugar up, which seems to have decreased events, but it's increased his weight. So you walk in the room, and gee whiz, you're wondering what this person has. The student tells you all this story, but having a diabetic family member, you don't know if he's taking insulin, or maybe has insulinoma, which is very rare, that we rarely see. So what do? Well, you tell Mr. Jones you're going to be back. You have the student go and look up what you do to rule out exogenous insulin administration or insulinoma. The student brings back the article, and you know what to order, and you go back in and talk to Mr. Jones to order the tests. While the student was doing that, you went and saw another patient. Again, improvement in productivity, student doing the research for you, and there are going to be other examples, certainly, of things that you haven't done in a long time or haven't seen ever. and have to look it up. I bring this example in because I had this happen to me. I had a dental assistant who was in the office next to me who came in and was in a stupor state. And we checked her blood sugar and it was 24. That's why I use that number. And I had to figure out how to figure out what was going on with her. And I had never seen insulinoma before in my life, and that's what she ended up having. And in fact, when I called the endocrinologist who, when I was admitting her, he laughed and thought he had never seen an insulinoma in his practice. So these things happen to us. So we have to have, it's nice to have somebody to help us look things up. All right, so productivity day to day. Here's what I did. So when I was in a practice, I had 12 patients on the schedule, and I had 2 people who called in to be seen. So I had 2 walk-in patients who wanted to be seen. I told them to bring them in. And so when the medical student arrived, we went over the schedule, and we decided which 2 patients that medical student should see to help me with the 2 patients that were going to walk in and be seen for an illness. And I took 2 of my longest patients for history, and I gave them to the medical student. And then the student went to see the patient. The student presented to me. I walked in and used that technique where I repeated some of the things that the patient said to the student, verbatim. And the patient knew that we had spoken, and the patient was seen faster and was satisfied with the visit. And so that's a technique to use to actually get the student experience and get the patient satisfaction that they need. So, effective clinical teaching issues. Now we get to what we do as attendings to make it a positive experience for students and patients. So it turns out that 40% of physicians report having experienced mistreatment during medical school and clinical rotations. Hopefully that's getting less common, but it still happens. So UC Irvine Medical School actually did this framework called the KIND framework for clinical teaching. And it avoids the perception of being mean. And sometimes you're not being mean, but just the directness of it makes the students think we're being mean. So first of all, knowledge sharing. As an attending physician, if you share the knowledge with students that you have just from being a physician for so long, going through your specialty, going through medical school, it expresses respect for the students' need to know. And that's an important thing. Giving them specific direction, telling them what you're going to do, whether you're in the hospital or the office, what the procedure is, what you want from them, helps them do the right thing. Especially in the beginning of rotations, when you're a third-year medical student or before in some medical schools, going into the hospital is a anxiety-producing event. The biggest probably is going into an operating room. Now, our simulation lab is trying to mitigate that a bit by having the students simulate operating room before they go in. But just remember when first time you went into an operating room and we had the fear of contaminating the field. There's nothing worse than that, And so really sharing that knowledge and actually admitting how it was for you as a medical student helps the medical students get more personal with your direction. The other thing is that they don't want vagueness and they don't want criticism, but they want opportunities to improve. Medical students are very driven. And what we've seen of these medical students is they want to do the right thing. And so that's what they're looking for. So they want feedback, but they want feedback in a positive way. And then to be inclusive, when you have a student come on the team, you make them part of the team. You welcome them as members of the team. You engage them as members of the team, and you make sure they're introduced to everyone. And that includes the non-physician parts of the team. In an office, all of the people who work in the office. In the hospital setting, all the people who you work with in the hospital. I always tell medical students and residents that if you don't listen to nurses and other staff at the hospital, you're a fool, because they are with the patient much longer than we are. And so they may have some insights that we don't get by seeing the patient for a short period of time. And then non-discriminatory. We do go through a lot of training at this university for unconscious bias, because we have those. We have assumptions that we make about people that are not accurate based on things that are not pertinent. And so be aware of that. And Be aware that you may think differently when a different person comes into the office than the last person, or the hospital than the last person. And so we really want to make people aware of that sense that we sometimes make judgments that are not based in fact. And then the feedback needs to be developmentally appropriate. So remember where a student is. I remember when I first got into practice, I went in with a more experienced physician right out of residency. And he said something that I found very true and that I lived with the rest of my career. And that is that when I walked into, it was an office in a hospital. We worked in a rural town. We had a 40-bed hospital. And he said to me, remember this, that when you're working with people, you're going to be the most educated person in the room almost every time. And he said, so treat those people with grace. That's important because we sometimes do that with medical students, but we sometimes do it with our own staff, with nursing, with other people. And we all have a place in the healthcare world. And so we want the students to learn that. We want them to know that they should be working in those teams. So when you're working with students, adjust to the student level. As attending physicians, we tend to talk at the physician level, the experienced physician level. And we really want to realize that students are not yet physicians, are not yet at that level, and they need to be taught in a different way. There's a difference between a beginning third-year student and the end of the medical school career fourth-year student, just like there's a difference between the first-year intern and the graduating resident. So we have to keep that in mind and always treat them with respect, but treat them where they are. And not as a colleague, but not necessarily as an equal in knowledge. The other thing is they're more experienced right now in basic science, so they might be able to run circles around us with the Krebs cycle. So. And then feedback. What feedback do learners want? They want feedback. They want it timely. They want to know when it's happening, when they're doing something wrong or doing something right. They want it to be in private if it needs to be. And they don't want to be exposed as making a mistake to everybody, even everybody on the team. So, and never do it never give criticism within the earshot of patients unless it's positive. And actually is a good thing to congratulate or compliment students when they do something good with a patient in front of the patient, because that gives the patient some confidence in what we're doing. But it does not help to give criticism in front of patients, because that kind of destroys the relationship we have both with the students and the patients. And then they want the feedback to be specific. You can't change a behavior unless you know what the specific behavior is. So if a student does a poor physical exam because they skip a certain part that you think they should have done, saying you did a poor physical exam doesn't help as much as saying this patient needed a good thyroid exam and you didn't even put that in. We need that in. So the student will, again, in private, so the student will say, oh, now I know what I did wrong. I will change that for the future. Whereas if it's just physical exam, they may think they did something else wrong and change it for the future, and it's still not what you needed from them. They want to know the techniques that you want them to use. You may have some depression surveys and other things that you want them to use. They need to know that. And they need to know your workflow, whether you're in the hospital or in an office. They need to know what you want them specifically to do in the workflow. So if you want the students to come in and see patients before you come to the hospital in a hospital setting, they need to know that. They need to know what time you think they need to come in to accomplish that. They need to know what you want then after they see the patient. They need to know how much you want them to put in the chart and what you don't want them to put in the chart. And these vary between attending. So for your practice, you need to tell them what you want them to do. Now, we do want them to do some documentation in the chart. So don't get me wrong. We don't want the attendings to say, don't do anything in the charts, because that's part of what they have to learn to be competent once they get to residency. I've been in this a long time. I was in this when electronic records first came out. And what I found was that a lot of medical students were never taught how to use an electronic record. So they'd come into the office, and even as residents, sometimes they never used a good electronic record. And so they'd come into the office or the hospital and they had no idea what to do. Well, we don't want that to happen. We want them to be able to do that as soon as they get into their third-year rotations. but we want them to continue that so they don't lose that knowledge. So really be clear about the workflow, whether it be the office or the hospital, and what you expect of them and what you want from them. And then be clear about professionalism. What is your dress code? How do you greet patients? How do you do things so that they become entrenched in your method in your office and that they don't surprise anybody? And then be objective. Don't say things that are personality based, but what you observe. So if somebody talks too fast, don't say you talk too fast, say, well, the patient had trouble following you because you went a little fast for them. It's what they need to know to be good at what they do. And this is their first opportunity to do that. And then always have a plan for improvement. It's best to have it's a 4-week block that the student will be with you. So it's best to have a 2-week time where you spend just 5 minutes saying, here's how you're doing. Here's what you need to do better. Here's what you're doing great. Hopefully there's some things. And then what do you need to improve and how do you improve them? Because they may not know how to improve the things that you want them to improve. The other thing is that most of all, be helpful. Be a mentor that wants to see them succeed. Be a mentor that wants them in our club because that's what they want. And it's a hard club to get in, as you know. So what's the benefit for all of you who are willing to be preceptors for our students? Well, you probably know this already, but if you get an appointment to the College of Osteopathic Medicine, you get access to the library, continuing education credits just for teaching the students in addition to the ones that you participate in that we're doing like today. We also will have in-person and online faculty development for the CME opportunities. This is our first online. The pandemic is increasing, so it's causing us some hesitation in the live events. But we have a couple of people in this room who are here, and we're being careful. So, and then remember the fact that it's easier to recruit associates, secondary to the opportunity to teach and to have education, especially in places where it's harder to recruit people. And then the access online content includes up to date, but it also includes, we added the prescriber's letter. And if you're unfamiliar with that, it's a monthly newsletter that goes over issues in prescribing, issues with medicine. It rates medication and goes through the literature to decide what is a benefit and what is not a benefit with certain medicines. It also has some natural products information in it at times. And for full disclosure, I'm a volunteer editor for that publication. I receive no compensation for doing that, but I do it because I think it's important because I have experience in those areas. What we're going to do next is we're going to show you an example of what's called the 1-minute preceptor. So you can see that it doesn't take long to take a medical student or a resident for that matter and teach them quickly what they need to do. And this features one of our medical students and our chair of primary care, Dr. Jimenez. Okay, so we got through this faster than I expected, but So in conclusion, remember, the patients generally do not perceive medical student participation in their care as a negative. They are usually neutral or positive about it, and they're usually very accepting of the process. So if you're concerned about using students in your practice, I hope this alleviates some of that concern. Again, I used students in my patient care throughout my private practice as well as in academics. And I never had a patient complain about this activity of students in the practice, providing they gave permission. I have had a couple of times where people had sensitive things they didn't want a student to be in on, but often they said, well, not this time, but next time I will. And so it really is not a negative in your practice. And I was a family doc who did OB and a lot of very personal care with people. And I still had no difficulty with students coming into my practice. Again, having students does not negatively impact the patient's perceptions of you. In fact, makes it more positive. They don't have, it doesn't affect their perceptions of your practice. They view it as a positive. They view that if their physician is teaching medical students, they must be smart. And of course, we all are, right? And then students can help a physician get through their day rather than hinder. And I think that you'll find that to be the case once our students start with you. Certainly, if a student is a hindrance, we want to know that because we want to correct that. They should not be, and they will not be if we have feedback that they are. And remember, the best teachers are actually the most productive physicians, because a productive physician says, I want you to go see the patient while I do this procedure, and I'll come and get you when I'm done, or you can come out when you're done. And so the productive physicians tend to give students more important things to do to get through their day. And it's a very positive thing for both the patient as well as the student. Remember that when you're busy, sometimes you are forced to give less time to a patient. When you have a student, you can make up for that with the student time. And then becoming a teaching physician can have a positive addition to your practice in all the ways we talked about. It can help you research things. It can help you do research by being a member of our community faculty. It can make your staff feel energized by having students come in and bringing something else into the practice that's positive. So keep that in mind and approach it from that perspective. And remember that all patients need to be informed and given the opportunity to make a choice about medical student participating in their care. But by and large, they will have a positive reaction to you asking them. Yes. Okay. So we're going to do a little bit of a follow-up test on what we talked about. And it's an easy one, true, false, but it allows you to get your CME. So. I'm going to give you about 30 more seconds to complete the test. They're going to see that. All right. So as you can see on this, first two questions, everybody agreed on. And I consider those the right answers. On the next one, I think I presented evidence that you actually can see more patients when you teach medical students if you do it correctly. And that's what this was about, methods of seeing more patients by using medical students to do it correctly. And then there is evidence in the literature that physicians who teach have less burnout because of the presence of medical students. And that goes back to the whole concept of medical students bring the reason why we became physicians back to us. And it takes away some of that frustration we feel with the changes in medicine that we've experienced over the years. Certainly, it's not going to change the burnout from COVID, but it can help us remember why we're here and what we're doing. And so I hope that the people who said that they can't see more patients by having medical students would review this and say, well, gee whiz, if I do those methods of having them see my patients who take a long time, I might be able to squeeze in another patient. It always worked for me. So now we have a chance for questions.
Advance it though to their survey so they can see it. Do you want me to speak to this? Okay, so shortly, I'm going to provide the link in the chat once I get done sharing the PowerPoint screen. However, if you would prefer, if you have your phone handy, you can open it up to your camera and you can scan the QR code and it's going to take you straight to our Qualtrics survey. And then from there, you'll be directed to our joint providership, which is in CEDO, to claim your credit. This is the claim credit code if you want to write that down. TIYZK. Again, I will be sending a follow-up email containing all this information though. So if you can't get to it right now, that's perfectly fine. We will take care of it on the back end. And if there are any questions, Dr. McKernan is happy to answer those and I will read those to him.
It looks like there are no questions, so I thank everybody who participated in this event and look forward to our next one, which is going to be on adult learners. Thank you.